This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance.
All right, guys. Welcome back, everyone. This is episode 14, I guess the start of season 2. It's our first time recording in 2022. Got some exciting changes and just continued growth of our team and podcast. One being that we have some upgraded audio stuff we're going to be using in the coming episodes, trialing it now, using some different software. So hopefully you guys have a better listening experience. And then our team continues to grow. So you guys might remember Nick, who came on as a discussant and masterfully walked us through his clinical reasoning on the case, and just really enjoyed the experience and reached out asking what he could do to be a part of what we're doing. So here Nick is today, and he's going to lead us in discussion with a case of his own. So I'll let Nick say a few words.
Sweet. Thanks for the introduction, Kevin. I'm super excited to be back. Thanks for the opportunity. It's going to be fun to be on the other side of this and listen to some of my classmates and their thought process on this. So yeah, just briefly introduction of myself before I pass it on to you guys. I'm a M3 right now. Right now, I'm super interested in ER and internal medicine. Still don't know where that's going to go, but we'll figure that out kind of closer to M4 year. And yeah, just super excited to be here. So I'll just, before we get going, we'll have two of our discussants today, Aaron and Berto, kind of just introduce themselves. So Aaron, you can go ahead.
Hey, everybody. My name is Aaron Park. I am originally from Tacoma, Washington, and spent about the latter half of my life in Seattle, Washington. I'm currently an M3 here at Rush Medical College, and at this point in time, interested in internal medicine. I don't think I'll deviate from that. Beyond that, possibly cardiology, maybe interventional cardiology or electrophysiology. And then favorite breakfast food, I would have to say a lox bagel. That is just a delicacy. I'm glad I got some support there.
All right, Berto, want to go ahead and introduce yourself too?
Thank you. Hi, my name's Jesus Varela. I actually have 4 names, but I'll just give you those 2. And then I go by Berto. It's part of my middle name. So I'm from McHenry, Illinois. It's just an hour north of here. I'm currently in M3. Career interests, I've been interested in neurosurgery for a while. So that actually comes up pretty soon. So I'm very excited to check that out for a couple weeks. Favorite breakfast foods, this is pretty easy. It's one of 2 things, either a Starbucks sausage, egg, and cheese sandwich, amazing road trip food, or chilaquiles. If you've never had them, it's basically an excuse to eat enchiladas for breakfast. So would recommend those.
Berto, and amazing. Like, I'm on board with that, but Aaron, you won my heart with lox, and I'm just going to plug, there's this place northside Chicago called Steingold's Deli, and they have the most fantastic lox bagel sandwich on an everything bagel. I wish I could have it every day. And then Nick, let's circle back to you. What's your favorite breakfast food?
I was going to say I felt left out. I didn't get to say favorite breakfast food. I have to jump on the bagel train, but I'm not a cream cheese person. So just egg on bagel, egg, cheese, bacon, whatever you can put on it, but not cream cheese. That's my controversial opinion.
And then we have Dr. Abrams here with us. Hey, Dr. Abrams.
I got to say, Aaron, you know what I'm having for dinner tonight? I am having an everything bagel, chive cheese, lox Nova, and that's going to be it. Probably a little bit of tomato and maybe a little bit of cucumber. So I had bought it the other day, and my wife and I have been saving it. I actually like it for dinner as much as I like it for breakfast.
I'm envious. I'll have to give that a shot.
I'm a team breakfast for all meals person. So
we'll get started here for our listeners who haven't heard our episodes before. We kind of just like to present the information in bits and pieces. So we'll start off broad with just our first aliquot of information and just hear what Aaron and Berto and all of us kind of just have to think about this patient, and we'll just kind of have fun along the way in hearing our thought process. So ready for the first aliquot? So here it is for you guys. You guys can see it on the screen. And for our listeners, this is a 74-year-old male who's our patient today. He presented to his PCP. Initially, he had some gradual onset low back pain. This had been going on for about a week. And he said it was mostly left-sided or midline. It was kind of difficult for him to characterize exactly where the pain was. But at this point, there was no known trauma or any falls that this patient had had. So I guess my question for you guys, just to start this off, would be, based on the information we know, what other aspects of this patient's history do you want to know when you're starting to work up a differential diagnosis for a patient like this?
This feels like a very generic answer, but I'd like to know the rest of his past medical history. I had a patient today who had low back pain due to metastatic cancer. And so I'd like to know if, that's at the forefront of my mind, somebody with prostate cancer or some other cancer that can metastasize. So that's usually where I like
I think I agree with Aaron. I just want to know a little bit more specifically since we're starting off with back pain. I like this mnemonic that I've learned for like the red flags of back pain because it's like one of the most common kind of complaints coming into the office. So I think, yeah, I'd want to know like overall more, but specifically I do have questions I'd want to know, but we can get to those now or later whenever we're thinking.
No, yeah, Bert, I think that's a super good point in terms of talking about red flags. And that's kind of one of the ways we're taught about working up back pain. 1% of patients have what we would call a serious cause of back pain. So for the vast majority of patients, this is going to be something that's musculoskeletal. But obviously, as clinicians or future clinicians, it's our job to kind of think one step further. Like, if this isn't musculoskeletal, what could it be? And red flags is definitely like a good way to think and differentiate about those. And actually, we already have one red flag here based on the limited amount of information we have here. You guys have any thoughts on what our red flag that we already have is?
I'll go out on a limb and guess that it has to do with no known trauma or falls. Normally, when people develop back pain, musculoskeletal in origin, it's after, jerking motions, heavy lifting, they slipped and fell or did something.
Yeah, definitely no known trauma or falls.
And I think I also want to add the age is pretty concerning. Obviously, we don't know anything yet about his past medical history, but I mean, somebody who's 74 years old, you're thinking some sort of malignancy or like prostate is like the common, it's like the classic when you think of an older man with back pain, prostate, any other sort of metastatic lesion to the spinal cord. But yeah, age, I think is definitely the most concerning. Yeah, age and again, what Aaron said are more concerning.
Definitely, yeah. So his age, he's older than 50. When we think about, so yeah, definitely that's already a red flag in itself. And then, yeah, like Aaron said, there's no known trauma. So that's less likely to be MSK in that sense. So yeah, you guys both picked up on that. Also, in terms of age, something to keep in mind is patients who are less than 18. That's also a red flag too. So not just older patients, but younger patients as well. And that's something that I always tend to forget about. Okay. So yeah, I guess we can move on to the next aliquot and then we can talk.
I got to say one thing, Nick, and it's just to almost pile on what was just said. So in general, back pain is actually most common sort of in that middle group, right? So you already said when you're old, we worry about it. And when you're young, we worry about it. This is purely anecdotal, but this for me, it's like 20 years ago. I herniated my L3, L4 disc. I picked up a piece of paper. That was the trauma. So be careful about that piece, because when you really think about it, you have to go back to high school physics and realize why that happens, because it's a bend and a twist and a torque that actually does the problem as opposed to anything else. But it's surprising how little you need to actually cause a big problem with your back.
Berto, I did want to follow up. You mentioned having a mnemonic for thinking about red flags. You mind walking through that?
Yeah, it took me a sec to jot it down, but yeah, so it's kind of funny. The mnemonic I like is the red flags. So T stands for trauma, H stands for history of cancer, E is extended. So like, typical MSK, somebody comes in, usually it's just like an MSK back pain, it's like some moderate activity, some NSAIDs, and usually gets better. But if it's extended, that's red flag. R stands for rest or night, which I really like that. It's kind of for a reminder for the inflammatory signs of back pain. So like if it's, it's worse with rest, it's worse in the morning, stuff like that. E stands for equina. So like any, like unilateral kind of sensory loss or incontinence, stuff like that. D, I think, stands for any disturbance. So like any kind of weakness disability, any sort of weakness. A couple more: F, fever, L, losing weight. A, like Nick mentioned, age. So age under 20 or over 50 is like what I like kind of have jotted down. G for any general symptoms. We kind of covered already fever and weight loss, but any other general symptoms you can think of. And then S, steroids or some sort of immunocompromise. So obviously we don't know much about this man's history. There's a lot of these red flags he could possibly have. So it'll be interesting to see, what we learn.
Yeah, I love having a thought process and like a mnemonic that you came up with. Just helps us like not forget. And honestly, like with all the information overload we have these days, just having some kind of diagnostic process to go to is super, super helpful. And I actually might use that one because I didn't have one before this. And yeah, I guess before we move on to the next aliquot, I also like to, you know, not necessarily just think about the spine when we're thinking about the back, because I always go there. I was thinking about the spine, but there's other, you know, organs in our back, our kidneys. In a, you know, in a man like this, something like a triple A or the aorta, something like pancreatitis can present in the back. So that's always something that I have to remind myself as well. All right. So for you guys, we got a good chunk of information here. Moving on. So this patient over the next 6 weeks, he had multiple visits to his PCP, kind of just due to this worsening, lingering pain. He had been prescribed some hydrocodone, which only provided some minimal relief. In the course of his outpatient time, he had a lumbar MRI. It showed some L5-S1 degenerative changes, but was otherwise essentially unremarkable. He was referred to neurosurgery. They did 2 epidural steroid injections, which provided some temporary relief, but the pain just came back. Additionally, he had about 10 to 15 pounds of weight loss, night sweats in this time, no documented fevers. His vitals were, he was hypertensive, otherwise normal, and past medical history like Aaron had asked for earlier. So he has paroxysmal atrial fibrillation, chronic mitral regurgitation, stable at this point, and also hyperlipidemia. And in terms of our social history, he had been before this in his usual state of health. He's able to walk around and perform all of his normal activities of daily living. So I'll have you guys kind of jump in with all this new info, kind of a lot to unpack, but how does this change what you guys are thinking? Rule in or rule out anything?
Yeah, for me, the weight loss is very concerning. Obviously, malignancy sort of jumps up on the list, as does the night sweats, you know, make me concerned about an infectious etiology, whether that's an epidural abscess or POTS disease, some sort of tuberculosis process. Berto?
Yeah, jumping in, I also agree with everything Aaron said. Also, aside from infectious, want to think of other kind of things that present with weight loss, night sweats, so like maybe B cell symptoms, some sort of other malignancy, like leukemia or lymphoma, something like that. Aside from, I guess, the typical ones you think of in a 70-something-year-old. I think I want to know a little bit more, I guess, just about before he presented. Like so you basically said he's totally fine. He was able to do everything, has no history of back pain.
Yeah, he was in his usual state of health. So aside from, you know, his past medical history, he was fine. He didn't have any back pain, and this did come on just gradually. But I will say, does our past medical history, because Aaron, you had asked about that a little bit earlier, does that lead you in one way or another? Does it provide any valuable information? We have some cardiac history there.
You know, I've got to think that the mitral regurg might be some sort of clue for all of this, but right now it's just not jumping. You know, it's not really jump starting any thoughts for me. And then I think that paroxysmal AFib, you know, I'm not entirely surprised if he's got this chronic left atrial stretching from the mitral regurg. And then hyperlipidemia in a 74-year-old guy. I mean, we live in the United States of America, so I don't get all that excited about that.
I guess just one more thing to add on. I guess I'm obviously pretty focused on the back pain and like the spine and all that, but kind of like Aaron said, maybe the mitral regurg, I want to know a little bit more about, like, when that was diagnosed. I want to know if there's other signs of endocarditis, and, you know, maybe there's some sort of another like an abscess, epidural abscess, which is a little different from initially. Like, I was thinking maybe just some sort of metastatic thing, but this could be an infectious cause.
Great. Yeah, I think you guys made a lot of good points, and honestly, the need for more information here is, you know, I'm sure we have a lot of questions. So we don't have all the information here. Going forward, what kinds of workup would you like to make based on this information? What other things do you guys want to know to kind of help narrow this down, since we are still pretty broad here?
I think I'd want to know a little bit more about the back pain specifically. We know it was like a slow onset, but I want to know, is it, you know, any sort of like ridiculous pain? Does it get better when he's shopping at the grocery store? You know, is it worse when he's walking? You know, stuff like that, just the quality of it, any sort of radiation, stuff like that.
And then you guys both kind of picked out the right mitral regurg as like, is it signal or noise? Is it a red herring in this case? How would you hope to gather more information about that, either through history or diagnostic testing?
I'd certainly like to know if he knows why he had mitral regurg, whether this is just from, you know, mitral valve prolapse, or if he had, you know, rheumatic fever as a kid and has some chronic heart disease as a result of that. You know, obviously the patient is our best resource here. I think the history that he can afford us is going to be really valuable. So just digging into that deeper with him. Nick, you were asking about what else, you know, in his history would we like to know. Berto said he'd be interested to know about other symptoms of this back pain. I'm curious about how the epidural steroid injections affected him, whether they provided relief or whether it was just, if it was asinine.
Yeah, that's a super good question. So they provided relief kind of in that acute phase in the couple days after the injection, but he didn't really respond to it in the way that the neurosurgery team would have expected if this was related to the L5S changes or just some chronic orthopedic disease. So the fact that kind of it came back, it wasn't really reassuring to them that that was an appropriate treatment, or I guess a complete treatment. There's something else for sure.
And then I think another question. So how long did it take him to lose these 10 to 15 pounds, the night sweats? He had that one visit after having pain for a week. And then we kind of talked about how he six weeks after was having, still had some back pain. When in the time course was this weight loss?
Yeah, that's also a really good question. So his wife was the one who reported the weight loss. She didn't know the exact number. She just, his clothes were looser fitting. She had expected at this point, this 10 to 15 pounds it had been about a month. So pretty significant there. And she had definitely noticed it and kind of felt that he was kind of getting a little bit weak with weight loss as well. So yeah, also I was wondering what you guys thought about no fevers. So when a patient has weight loss and night sweats, but they have no fevers, does that mean anything to you, or does that kind of, you just kind of assume there's inflammation going on? Or yeah, he's afebrile. So do you guys have any thoughts on that?
Yeah, Berto mentioned that one of the red flags is, and I don't remember how you put it so eloquently, Berto, but in your nice little mnemonic, I think there was some mention of fever, and that points towards like an epidural abscess. And the fact that this guy's afebrile makes me think that that's less likely. That falls further down on my differential. As for the night sweats, I think Berto already hit the nail on the head saying that makes you think of, some sort of, B-type symptoms, whether that's disseminated lymphoma or what have you. And that coupled with the weight loss, I would completely agree.
Awesome. All right. So should we move on? So yeah, our next aliquot is some lab data, and in addition to a little bit of other data as well. So in the course of his outpatient workup, he had some electrolytes. His sodium was low at 130, but his potassium was normal, chloride 95, CO2 was 28, anion gap was 7. His creatinine was normal at 0.81, and glucose was 129. Albumin was low at 2.5. Calcium, non-adjusted calcium, was low at 8.4. His Billy's, LFTs, alk-phos, all that was normal. He had a CBC as well. His white count was up at 13.5. His hemoglobin was 13.3. His hematocrit was 39.5. And his platelets were 368. I will say that the 39 and 13 for the H&H here, and that actually did continue to downtrend a little bit in the next couple of weeks. He also had a TTE. This was done as part of just a routine cardiology visit for his chronic cardiac disease. It showed normal systolic function. Yes, 71%. It redemonstrated his severe mitral regurgitation. There was age-related aortic stenosis, but otherwise the other valves were unremarkable. And then he also had a UA, which was normal. What do you guys, does anything shoot out here? Are any of these labs helpful for you, or the echo or UA?
I think quickly to mention about the albumin calcium is I don't think we know if the calcium is truly low, if the albumin is 2.5. If this is, total calcium, I think we would expect it to be low because calcium, binds to albumin. And if we're running low on albumin, we're not going to have as much calcium. So I think either the calcium could be truly low or it could just be related to low albumin.
Signal first noise there. Go ahead.
I would say the one thing that sort of excites me here is the sodium of 130. I'm not surprised that a 74-year-old guy has a hemoglobin of 13.3, and the albumin and the calcium are. Yeah, I mean, the albumin is definitely low. The calcium, that doesn't freak me out too much. But a sodium of 130 in a guy who doesn't have much explanation for it, unless he's telling me that he drank a gallon of water before he went and got his labs drawn. I don't know what to make of this, whether this is some sort of adrenal insufficiency. I would have expected other electrolyte abnormalities.
I guess one more thing to mention is we don't know, do we know his total protein? I was wondering if we could check out the gamma gap to see if there's a hint of anything else in his serum. We know the protein is low, the albumin is low. We don't know how high his total proteins are, so there could be something else in the serum. Just looking at the albumin.
Yeah, that's actually a super good point, Berto. I don't have the exact answer for you in terms of the total protein. Put me on the spot there, but
No worries.
I will say that, and this is something that No, they did as an outpatient, they did do an SPEP, and they did do kind of a little bit of an evaluation for multiple myeloma, kind of given the anemia and back pain. And that did kind of show a monoclonal gammopathy of undetermined significance, which the heme team had later kind of just said they could work up later, and it wasn't multiple myeloma or anything. But yeah, I think that's super interesting you brought that up, because those are actually questions that they did ask. And for simplicity's sake, we didn't actually include that in the aliquot, but you're one step ahead.
Yes, very intuitive.
Very
not
straightforward.
not in the right direction. I put that together with the back pain, and but
Yeah, no, you that is totally the right direction. And that's actually what happened. So but yeah, in terms of total protein, don't have the answer for you, but in terms of the low albumin, kind of you're looking at the low albumin and kind of thinking about a patient with progressive, he's got a little bit of an anemia, he's got progressive night sweats, weight loss. Does the low albumin in that context mean anything to you guys?
I mean, I know you can have like a protein losing enteropathy with heart failure, so if they have, their ejection fracture. Okay, actually, hold on. So we said they have severe mitral regurg. Okay, so I think with severe mitral regurg, 71 seems high, but it's probably lower than it really is, because with mitral regurg, right, you're getting more basically into the ventricle. So I think actually anything, well, obviously they're over, but anything less than 60% is a really bad sign in mitral regurg, because again, it's like kind of a false, EF, just because you're having that increased preload. But yeah, I think the only connection I can make right now is with heart failure. Maybe they're just losing some protein because of that.
I think that's also another really intuitive thought, and something that just jumps for me with albumin 2.5 in the setting of his history of about 4 to 6 weeks now of B-type symptoms. This is just supporting evidence of that. So there's some kind of metabolic phenomenon happening that's causing him to lose weight, and it's reflected there in that albumin.
One other comment just about the rest of his labs, this white count of 13.5, I know very non-specific, but I think to me that brings back like osteomyelitis onto the table, which I had decreased during our last aliquot because, he's afebrile and this has been going on for so long. But I think, in some patients who, have chronic osteomyelitic changes that, they may not be able to mount a long-standing fever like this, or may have sort of this insidious elevated white count. So
I love what you just did, Aaron. Even if you don't know what you did, you just totally invoked Bayes' theorem there by saying you decreased your thought process centered around osteomyelitis, but then this new post-test now kind of finding of a white count elevated supporting some kind of inflammatory or infectious picture raises that again. So just like how you're able to adjust your diagnostic clinical reasoning as information is presented, that's amazing.
So mathematics is for me and not medicine.
No, your integration of mathematics into medicine is going to make you an amazing clinician.
I guess one more thing about this white count, Aaron brought up a great point. Maybe maybe he's afebrile, but it's not, maybe it's fake. Maybe he's just immunocompromised, or maybe he's on some medications we don't know about yet, but if he was a younger, healthier person, he could have a fever. So with that being said, I think I kind of want to know maybe if he has any sort of exposure history or like TB risk, maybe thinking like Pott's disease or anything like that. Kind of like Aaron said, I took that off the table, but with his older age, maybe he would have a fever normally.
Yeah, I love what you just said, because kind of when I was asking about fever earlier, and just the fact that just because someone doesn't have a fever doesn't mean that they don't have inflammation or that they don't have infection. And you guys said, I mean, in terms of being immunocompromised. So you guys are asking about history of immunocompromise or something that's going to stop the body from mounting an appropriate like inflammatory response. And so, yeah, the way you guys adjusted, that's definitely something that's important for our thought process going forward. So, and then also, yeah, in terms of these labs, to be honest, like, I mean, they tell us some information, but it also is very underwhelming. There's a lot that's just not here. And like, we can sit here all day, try to figure it out, but we just don't have enough information yet. And I think that's kind of what the fun part about this too, is that we already have so many thoughts and we really don't even have that much info. So on that note, I think we can get more info, and I really like this next aliquot. So about 6 weeks had passed since the original presentation. So since its first PCP visit, this is now 6 weeks into the future, the patient was admitted to the hospital for worsening fatigue, some weakness of the lower extremities, night sweats, the weight loss about 20 pounds. He had 2 mechanical falls kind of in the week or so preceding the admission. One was witnessed by his wife. He had fallen on his back. The other was unwitnessed. And his wife kind of just said, he's really not able to take care of himself in the outpatient setting. And that's kind of what eventually brought him to the hospital. So his initial vitals, 105/72 was blood pressure. He's afebrile, 100 beats per minute, so mildly tachycardic there. And then he had a respiratory rate of 12 and he was satting 97% on room air. HENT, respiratory, abdominal, MSK, and neuro exams, they were all normal. His cardiovascular exam, he was tachycardic, regular rhythm, S1 and S2 were normal. He had holosystolic murmur that was appreciated over the left fifth intercostal space, and there was 2+ bilateral lower extremity edema. He had a chest X-ray, a CT brain, a CT spine, and CT C-spine and L-spine, which were unremarkable for any acute processes. And then he had also started to complain of some new worsening pain in his right shoulder. So a lot to unpack here as well. What do you guys think? Anything stand out to you here?
Yeah, I'm concerned about what looks like an exacerbation of his heart failure. The fact that he's compensating by being tachycardic, you've got signs of over heart failure on exam with this 2+ bilateral lower extremity edema. It sounds like that has become more of a concern in terms of his ability to maintain a functional status. I'd be curious to see his labs at this time and a repeated TTE. Like Berto had mentioned before, the relationship between heart failure and hypoalbuminemia, I could see that being worsened now.
And then I just have a quick question. I think just to fill in a gap I have, did we get a medical med history? Is he on any medications? I'm sure he's on something at least for his AFib, but anything?
Yeah, super good question. So he was anticoagulated for his atrial fibrillation. He's also on dronedarone for some rhythm control, and then he was taking, I believe, it was atorvastatin for hyperlipidemia. So yeah, he had the otherwise, yeah, I don't think he was on any other medications.
I say that second medication one more time.
Dronedarone, the antiarrhythmic. I think that would be the class 3 antiarrhythmic.
What were you thinking in regards to medications, Berto?
This is kind of random. I was just thinking, we know he has a history of anemia with severe mitral regurg and the possible aortic stenosis. Is that correct? There was some sort of, or was that
On the original echo, there was mild age-related changes of aortic stenosis. Yeah.
I think just something I thought about real quick is, or a possible cause of this anemia is Hyde syndrome. Basically, like if you have some sort of calcification, basically just can kind of lead to some bleeding, some occult loss of bleeding that can accumulate. And then, so then that also got me thinking, like, has he ever received like blood transfusions or anything like that? Because then you start thinking about, the kind of complications that come with frequent transfusions. But yeah, that's all I was thinking there.
Yeah, great thoughts.
And then in terms of also, I thought interesting in terms of the shoulder pain, they had examined the shoulder, but so his shoulder pain really was something that he kind of had complained about on his first day of the hospitalization, and kind of it was not ignored, but in the context of what was going on, it wasn't really something that was given too much attention until he really did complain about it more constantly than what would be expected for just shoulder ache. So kind of giving that information, he does have this joint pain that seems to be a new onset as well. Does that bring in any thoughts for you guys in terms of differential here, or just in terms of causes of shoulder pain in isolation?
Related problem, separate problem.
I'm going to have to say it's related. Occam's razor. I just like to go for that.
And we totally do not have enough information right now to relate them at all.
May I ask, was this a shoulder that he perhaps fell on when he had these 2 mechanical falls?
Possibly. That's actually a super good point. That's possibly something they had thought originally, but no, I don't think that he, at least, or his wife had said that he had fallen on that shoulder. So it's thought to be non-mechanical, but of course something that, we're not 100% sure of that, but at this point it was thought to be non-mechanical.
Well, I think also looking back at it, the heart failure would probably explain his hyponatremia. So I don't know, it seems to be focusing more cardiac, a lot of these symptoms. Again, I think the albumin, we can connect back to heart failure, hyponatremia. So not to like block us down that path, but the heart is really kind of sending a lot of signals here.
You guys think anything of the murmur?
I mean, I think that, to me at least, the echo sort of explains this holosystolic murmur, especially heard down at the apex of the heart.
Yeah, for sure. Yeah, known mitral regurgitation, definitely a physical exam finding that you'd expect there. Should we move on to some more info here? All right. So, hospital day 4, the patient has an acute change in mental status. The nurse noted that overnight he had some episode of slurred speech. They did a CT brain, showed some low density focus in the body of the corpus callosum to the left midline with mild mass effect. The radiologist had recommended that they obtain an MRI to further characterize that. However, in the next couple of days, they were unable to obtain it just because he had some trouble sitting still in the MRI machine. He now spiked a fever to 101.5, and they took blood cultures which grew gram-positive cocci. He was started on vancomycin at this time. So yeah, we have this acute mental status change, CT brain findings now, a fever, now blood culture positive. So and this was kind of all that happened in the acute setting in the hospital. So any thoughts here? What jumps out to you the most, or kind of in combination?
I'd like to defer to the budding neurosurgeon on the evaluation of the CT brain.
Consult neurosurge.
The thing I theoretically have about 8 years of training left. So,
and I would say that in terms of like the exact read, it was a little bit vague. I wouldn't go too much into corpus callosum and all that. Just the fact that there was some low density foci in the brain, there was an acute mental status change, slurred speech. What are you thinking as like the thing you're most worried about here?
yeah, I mean, so the biggest thing you want to do here is, I mean, you're thinking of a stroke whenever there's some sort of altered mental status, slurred speech, especially anything like that. You're thinking of a stroke. So CT sounds like, yeah, there was some sort of focus, but no blood. So I'm sure they followed the stroke pathway. So yeah, if they figured out there was no blood there, that's maybe a sign of an ischemic stroke, or some sort of embolism, something else that got lodged there.
I'm going to ride your train, Berto, and say that makes me think of septic emboli. You've got these positive blood cultures. He's now febrile to 101.5. We know he's got this damaged mitral valve. It's a perfect nidus for an abscess. And so, I don't know if his mitral valve is throwing off these little septic emboli all over the body, but yeah, that's where I'm going with the CT brain.
Yeah. And then, I mean, with this history of AFib, who knows, he could possibly, he's on anticoagulation, but who knows how that's going given his possible hypercoagulable state with this, possible malignancy. So I think could just keep adding to this, and he's probably throwing emboli, like Aaron said.
That is awesome. And going back to the shoulder pain, you want to throw that in here? Does that make sense at all here as well? And it doesn't have to. So yeah, I mean, you guys basically just took this new information here and kind of essentially explained a lot of what's going on. And you guys also talked about kind of pathophysiology, and you use the medical history to kind of also form a hypothesis, in terms of the medical history of valvular disease. You mentioned you're using that information in addition to the kind of more objective clinical information we have in front of us. So I thought that's super impressive the way you guys did that.
That's one quick thing I want to ask. Does he have a history of kind of going down Aaron's pathway, like any GI, GU kind of issues, like when was his last colonoscopy, like any BPH, any sort of history?
Can you explain your reasoning?
Yeah. I was going to say before I answer that, what you thinking?
Well, some of the classic things I've locked in my brain for step is, I mean, some people, certain populations have like classic causes of endocarditis. For example, you think people who use IV drugs, like you'll think Staph aureus, right? Anybody who's had GI, GU procedures, you'll think of Galolyticus, for example, or actually, sorry, Enterococcus, right? And yeah, Enterococcus, people who've had, so if you find Galolyticus, right, then you want to like look for colorectal cancer. So, and then with his back pain, I think a lot of these different kind of causes are on the table, but I just want to know when his last colonoscopy was, any sort of GI, GU issues, kind of like we mentioned. Kind of doubt it, but well, I guess, any history of drug use, anything else, Aaron, that you can think of?
No, but I'd like to say, I think that was a very astute observation. Mind you, he's got a lot of explanation or, things to sort of tie back into this potential colorectal cancer. He's got this anemia, which I think would be reasonable to presume would be iron deficiency. Just the proximity, whether he's having metastatic spread there, and now these gram-positive cocci. Yeah, I think I like the way you're going.
Just to add to that one more layer, sorry to any internal medicine people listening, but another thing we've learned is if any older man has an iron deficiency anemia, it's basically like colorectal cancer unless proven otherwise. So I think we could have jumped on that, never too late. So I guess jumping on that now, we probably should have asked sooner about any colorectal cancers, but the iron deficiency anemia in an older man was definitely a big red flag for that.
Oh my God, I love your guys' reasoning right now. This is amazing. I was wondering right away when you were asking for more info about GIGU, if you were making that connection where you're like, were you thinking this is a malignancy and you're trying to tie it to a bug, being that we have some signal coming from the heart? Because base rate of disease this is Staph aureus until proven otherwise, in my opinion. Just it's very unlikely to be something else. We don't have like the supporting history of IV drug use, but it's still the most common bug for valvular endocarditis. But I love how you're framing information we've already gathered that's supporting this picture of malignancy that you guys have both been suspicious of since the first aliquot. And you're tying that in. So just fantastic job, guys.
I guess one more thing to add is, I mean, if we're really thinking, some sort of malignancy, he has this right shoulder pain. I mean, it could be a met that went to the lung. It could be causing, like if it's at the apex, it could be causing those symptoms, like the shoulder pain, weakness. I think that could be causing it.
May I ask, where was his right shoulder pain? Was it a pinpoint? Was it an acute location? Or was it very generalized? Was it posterior towards the scapula?
Good question. It was very generalized. Involved the whole shoulder, could not localize it, and kind of just all movements hurt it.
And was that anything else on physical exam? Like how's his overall strength, pulses? Is his arm, are his limbs warm? How is his limb doing otherwise?
Yeah, all super good questions. So yeah, his pulse is his okay. In terms of his neurologic exam, they had done quite a few neurochecks after his acute altered mental status change, and they were significant for a little bit of weakness in the right leg, but nothing else really screaming out on the neuro exam. He did come in with a little bit of baseline weakness in both of his legs prior to kind of on presentation at the hospital. That is thought to maybe be related to why he was falling. He's just kind of weak there in both legs. But yeah, I think those are all really good questions in terms of like just continuing to ask for a detailed physical exam. If you were to examine the shoulder, what are some things you'd look out for in terms of like maybe more of a global cause?
I'd like to look at range of motion, both passive and active, try to see if, like I alluded to earlier, I was wondering if this was pain due to one of his mechanical falls. I'm thinking if he tore his labrum or something. This is under the context of this shoulder pain is unrelated to whatever disease process he's got underlying all of this, and it's just something else that we're working up at the time. I gather you guys wouldn't lead us this far down this path had it not really been that exciting or pertinent to the case. But I'd still like to consider rotator cuff injury, tendinopathy or tear. We're concerned what sounds like a damaged mitral valve throwing clots off. It's not out of the question that he could have thrown one into the, anatomy was never my strong suit, but the brachiocephalic artery, is that right? And concern for like acute limb ischemia. But if this is, because this sounds like it's more insidious, then I'm not really that concerned about that.
Yeah, I think that those are all good points, and I love you're just continuing to keep everything wide open in terms of your thought process, and kind of like you're refusing to anchor on any certain thing. And you guys always asking more questions kind of about like his exam and all those points. So I will say now, based on this information, what would your workup now be to either confirm what you guys were thinking or kind of investigate anything further?
I want to add something real quick again to the shoulder pain. This is all over the place, and this is a super interesting case, but I still feel like it's probably connected. So I want to say, talking about the shoulder pain, I think I want to know more about, Aaron covered it, but also maybe if there's some neuro symptoms involved, ptosis, meiosis, and hydrosis. Like I mentioned earlier, if there's like that tumor at the apex, right? This is so strange because we think it's endocarditis, but also think malignancy, which both could coexist, like we're saying, right? That's kind of our theory. So say the colorectal cancer did spread to the lungs, he could have a superior sulcus tumor that could be causing, like, do you know how's his neuro exam, like cranial nerves, all that?
I don't have it in front of me.
That's totally fine.
And so but I think that, that's something that I didn't even think about. And honestly, it would make sense. You're kind of taking the anatomy as well and trying to relate that into this clinical context, which is actually really like super advanced. And that's not even where my brain can go at this point. So yeah, I will say there was no like gross unilateral swelling of the face or like there wasn't any or bilateral swelling or neck or anything that they had noticed, but also just like super impressive thing to think about and bring up, I would say. So going to in terms of workup, so like if we had wanted to order something to kind of confirm what you guys are thinking, then what kind of steps would you take here? What's some kind of more information? Obviously that brain MRI is on its way.
I mean, I'd like to see a little bit more blood work at this time, but also thinking in terms of bigger picture, big ticket items, I'd like to probably see a transesophageal echo, get a better look at his mitral valve, see if there's any vegetation growing. Yeah, I feel a little embarrassed that we didn't mention this earlier when we saw the results of the CT, that we didn't at least question whether there was some brain metastasis. And if we did, then it was in one ear and out the other. I didn't pay attention to that. I don't know how frequently colorectal cancer metastasizes to the brain, but it's certainly not out of the realm of possibility.
I think a couple things I want to add. Well, first of all, hopping on Aaron's train, whatever the metaphor is. I recently learned I'm on surgery right now, and I got scrubbed into a transplant case, and I learned that up to this is actually a mind-blowing number, but apparently 70% of colorectal cancers can metastasize to the liver. So I definitely want to include the liver in the CT scan. Yeah. So that's something interesting to think about. Second, I want to I don't have Duke's criteria memorized, but I want to pull out and check out what Duke's criteria has to say regarding endocarditis, along with Aaron's echo.
I will add, Aaron, if you got something to go on.
Well, I just have one more thing to say, and I hope I'm not stealing your thunder, Berto, but I think a colonoscopy is in order. Like you said, iron deficiency anemia is a GI bleed until proven otherwise. Let's look up there and see what we can find.
So a couple things here. First of all, this patient did not have a colonoscopy done within the guideline recommended period before this. Second of all, I just wanted to say super impressed that, okay, so first of all, Aaron, you said you wanted an echo to see vegetation as a next step, which I would totally agree. That's like an awesome next step. And then Berto, I think that your suggestion of imaging, multiple organs, like you talked about in the abdominal organ, including the liver, because we have a process that seems to be a systemic process here. That's actually like a really, really interesting point. And you'll see on kind of the next aliquot that's one of the strategies that the medical team took is that, we have shoulder pain. Now we have something in the brain, we have the heart involved, kind of taking a look intra-abdominally or just kind of broadening that, because if something goes wrong somewhere, it's more likely to go wrong somewhere else as well. So that is also super impressive. So I think on that note, our next aliquot. So we had a CT chest, abdomen, pelvis, which showed some cardiomegaly, likely volume overload. And then there were 3 peripheral wedge-shaped hypodensities in the spleen. The lumbar MRI showed inflammation around the left sacroiliac joint concerning for septic arthritis. And then they also had done a right shoulder tap.
Why don't you guys discuss the imaging findings first, and then we'll get into the details of the shoulder tap.
I'm seeing wedge-shaped, and I think we need to get this man on and every antibiotic possible. And I mean, this just adds to what we've been saying. I think he's just throwing a ton of emboli, and I mean, again, it could be endocarditis. It could be he's just hypercoagulant and throwing clots out. Maybe a mixture of both. But the wedge shape in the spleen, I mean, yeah, those are infarctions. That's obviously very concerning. The septic arthritis, again, like that supports he's throwing septic emboli. I think that's maybe that could be a cause of. Obviously, you want to keep an open mind, but just keeps kind of supporting that he's tossing out.
Sweet.
I have nothing to add.
Going off that, then could you maybe anticipate what the results of his shoulder tap would be?
I am going to hazard a guess that it is septic.
Not a trick. All right, yeah, we can show him here, so you guys can see his synovial fluid analysis. They did a tap of his shoulder, and just for our viewers, it was of the right shoulder. It was grossly xanthochromic appearing with moderate gross blood. White blood cell count was about 64,000 with 20,000 red blood cells. And then his polymorphic nuclear percentage, so percent neutrophils, was about 95%. There weren't not any crystals. So this, yeah, you guys can go ahead and kind of also, you can go over maybe a thought process in terms of how you guys would like interpret this. But yeah, really just kind of lining up with the picture that we're seeing here.
You can go ahead if you want.
Like I said earlier, I kind of cut to the chase and said this is septic arthritis, but yeah, this fluid count and culture kind of just looks exactly like that. I mean, you've got a white count greater than 50,000. You don't have a better explanation. You already know he's got septic arthritis in one other in one other joint. So, all clues point towards septic arthritis here. What I'd like, well, maybe this is extraneous, but culturing this synovial fluid and seeing if it's also going to grow gram-positive cocci, similar to his blood culture.
Yeah, I think you nailed it. So yeah, they did end up taking a culture. I think that's a super good point. I also thought it's a super good point. You mentioned kind of that 50,000 mark on the white blood cells. Just doing a little bit of my own research around this. So, we're kind of taught that 50,000 is kind of like a diagnostic threshold for something like septic arthritis when it's above 50,000. That's exactly what you mentioned. So I'm super supportive of it. I also thought it was interesting and not really specific to this case, but that 50,000 is actually really good for ruling in septic arthritis, but it's not something that's really great for ruling it out. So studies, they looked at this in the American Journal of ER in 2007, and they basically had taken a bunch of patients who were culture positive on their synovial fluid aspirates, and they found that 40% of those patients had white blood cell counts that were less than 50,000. So basically, just big picture here is that it's not really that sensitive for picking it up, only about 60%. So if it were to have been under 50,000, but we're so convinced with the clinical picture that we have, then we could still say that this is likely septic arthritis just based on all of the other information that we have. But because, it's over 50,000 here, and all the supporting evidence just kind of backs it up. So I thought that was something interesting, kind of a little tidbit that I learned researching this.
Another budding mathematician. I think Russia's doing something in terms of the EBM front.
Yeah, that is exactly. Yeah, maybe Aaron, we can go in on something. And then, yeah, and just in terms of approaching synovial fluids in general, like the most important things are the gross appearance. We're looking at the white blood cells, the gram stains, like you said, crystals. And then so we usually like to use 2000 like as a marker for whether this is inflammatory versus non-inflammatory. And that's like a really good branch point. So non-inflammatory being things like osteoarthritis, trauma, avascular necrosis, and then greater than 2000, that kind of opens the door to more inflammatory causes, which we saw in this case. And then if it isn't inflammatory, you want to say, like, are there crystals? So could that suggest some kind of gout or pseudo gout? And if there's not crystals, then yeah, we're thinking bacterial causes like septic arthritis, but there's also, inflammatory causes like RA, spondyloarthritis, Lyme arthritis, things like that as well. So just in terms of a general approach to these synovial fluid analysis.
I just kind of want to summarize what Nick did there, because I came off room to end 2021, and we do arthrocentesis was something is bread and butter for room. But I think Nick captured it perfectly. It's inflammatory or not, then it's infectious or not. If it's infectious, culture it. If it's not infectious, are there crystals? If there's not crystals, something autoimmune. I think that's a great way to approach it.
For sure. And then just kind of moving forward, like with the rest of the case. So this patient ended up, having that TT, like you had said. So yeah, if we want to move on to the next aliquot. Yeah. So he had a repeat TT, and then the brain MRI was obtained. We obviously, and then a shoulder MRI as well. So just telling you that we did get those things, and based on everything that we had talked about, you guys want to kind of just finally say what you think the diagnosis is in the most eloquent way possible based on all these findings here. I think that I will say you guys have done a pretty good job getting there so far, so I don't think it will be super hard for you at this point.
Yeah, I mean, I don't want to steal Berto's thunder, because I think he was the one who really sort of elucidated this first, but I'm going to do it anyway. It sounds like there's colorectal cancer. I'm going to say the bacteria that's causing him to be septic, and that's grown on his mitral valve, is probably strep bovis or strep galolyticus. I don't really know which nomenclature we use nowadays. And he's thrown septic emboli to what sounds like his brain, his spleen, his sacroiliac joint, his right shoulder. Yeah, kind of a catastrophic septic emboli shower.
Yeah.
For your
Exactly.
review, let me challenge you guys, and at least for discussion's sake, what if it wasn't bovis or galolyticus and was something else?
I think like what you had said earlier, Kevin, about Staph aureus, whenever we see a blood culture grow gram-positive cocci, Staph aureus, of course, jumps to the forefront of your mind. And so, maybe it's too poetic to try to tie these GI and lower back symptoms in with these cardiovascular symptoms, but they could be unrelated, but just the fact that he had them occur at the same time, who knows? Very coincidental. Or coincidence.
I'd like to add that, we knew he had a history of mitral valve disease, some aortic stenosis. It was a slower onset endocarditis. It seemed like, it went on for, it sounded like 6 to 12 weeks, right? Kind of was the timeline. I think we could also think of like viridans, which is this more slower growing bug. and, usually no big deal. But if he did have, any injury lesions to his valves, that could have definitely been a little bit easier for Viridans to grow. And again, that'd be more of a slower onset. I think typically with like staph, I think of like a super quick, it just like goes in and like destroys your valves. Obviously maybe, clinically it can be very different, but I think of that one as a more quicker moving one versus the slower insidious onset makes me think it could be something else. So like what we're thinking, Oregon, like I said, Viridans. Yeah.
Amazing, guys. Amazing.
Yeah. So I will say amongst our discussion in this last hour, you guys named the organism. And I will also say that you named the organism without even having any information about whether or not this patient had a colonoscopy or not. You guys kind of just, you used your brains to ask that question. So I really, to be honest, I expected, or I didn't even like expect you to go that far. And like you pretty much nailed this even to pretty much the organism as well. So final diagnosis, subacute enterococcus fecalis endocarditis, complicated by septic embolic phenomenon. Pretty much nailed it on the head. Super impressive. And I really enjoyed listening to you guys get to that diagnosis.
I would love to know now, did this guy have a colonoscopy, and how do we explain this enterococcus? Because these guys jumped on that so quickly.
I know.
Do we have any resolution?
So this patient was, based on after these blood cultures, they had recommended that he get a colonoscopy as an outpatient. I will say I followed up on him in the medical record, and I don't see that he has gotten a colonoscopy, but I will say that in terms of the actual Enterococcus fecalis organism itself, so they had actually done some retrospective studies, did them at Mayo, and they took a cohort of these patients with Enterococcus endocarditis and patients who didn't really have any source of the Enterococcus, and they found that about 15% of them did have advanced adenomas or colorectal carcinoma on their colonoscopies. So not exactly sure the outcome if that's what happened with this patient, if that was his source, but it is recommended that a patient like this does get a colonoscopy. And then for fecalis itself, this is our third most common cause of native valve endocarditis behind Staph aureus and strep. So it causes about 11% of cases, and it's gram-positive coccus. It inhabits our gut. It's a commensal, but it can cause a variety of infections. UTIs are the most common, endocarditis for sure, like we saw here. Kind of like in this case, it usually presents as a more like subacute bacteremia, much less likely to be something like septic shock or something really extreme and acute like we'd see for Staph aureus. And so that could be a possible explanation for why this patient kind of just had this kind of smoldering infection, bacteremia over the course of time. And so, yeah, I think that the organism kind of does like retrospectively makes sense and in terms of kind of why this was such a subacute kind of gradual progression. And yeah, so I do have some other teaching points. I don't want to do like a full lecture here, but so you guys can feel free to pitch in as well. But just in terms of some kind of things we can bring home from this case. So in terms of our diagnosis, Berto, you had brought up the Duke criteria. And so I'm not going to go over everything like in detail. I'm not going to go over the full criteria, but for this individual patient, so our Duke criteria is a really well-validated diagnostic tool for endocarditis. And we can use two of the major clinical criteria. So in this patient, he had the positive blood culture for a known organism, and also there was a vegetation on the echo. So with those two things, we are able to make the diagnosis of endocarditis. So that's how we did it based on the Duke criteria. And then I think the big picture learning point from this case today was really the complication that can happen with endocarditis, not just the endocarditis itself, but all of the systemic processes that can happen. Really it's widespread, can affect essentially any organ system. So cardiac complications are going to be the most common. In about half patients, you're going to see them. And of those cardiac complications, heart failure is the most common. It's also the most common cause of death. It's usually due to direct vegetation affecting the valve, so causing valvular insufficiency. You can also get perivalvular abscess in endocarditis. And rarely you can even have septic embolization into the coronaries, so causing ischemia and infarction. So all like really serious cardiac complications. And again, the cardiac ones are going to be the most common. But as we said, metastatic infection, so embolization, like abscesses to organs like the spleen, and also mycotic aneurysms, usually like at branch points due to kind of the chronic bacteremia effect on the vessel wall, can also be an effect of endocarditis. Moving on to MSK complications, so septic arthritis, which we saw here, also vertebral osteomyelitis, which Aaron had brought up as a possible cause here. And so I also thought it was interesting that when you have kind of joints that are involved in the axial skeleton, so like the sacroiliac joint, which we saw, that can kind of be a clue as to something like a septic arthritis associated with endocarditis. Neurologically, we saw, so cerebrovascular events are really common. Stroke is the most common, and that's most common in the month after diagnosis, but can be before or after the actual diagnosis of endocarditis. Renal infarction and abscesses can occur. When these patients are treated with antibiotics, it often requires like really long-term treatment. So when we think of effects, renal effects, we're also thinking of renal effects due to treatment. So, we use aminoglycosides, we use vancomycin to treat endocarditis. So the renal effects from treatment are also something to keep in mind. And then pulmonary. So if it's right-sided, you can have septic pulmonary embolisms. If it's left-sided, you can have pulmonary edema from heart failure. So those would be pulmonary complications as well. And then if that was not enough information for you, the last thing I kind of wanted to go over, which was kind of a question we had clinically, is does this patient need surgery? So this patient had endocarditis, he got a vegetation on his valve. Can we treat him with IV antibiotics or does he need to go to the OR? So we have common surgical indications for infectious endocarditis. Number one is there acute heart failure? So acute aortic or mitral valve regurgitation. Does the infection extend into the heart? So are there abscesses? Is there a heart block or any fistula in the heart? That would be an indication. Is the organism really difficult to eradicate? So if it's a fungus or something that's multi-drug resistant, or there's persistent bacteremia despite appropriate antibiotics, that's also an indication for surgery. And then lastly, we have the size of the vegetation. So we generally like to say that left-sided vegetations greater than 1 centimeter or right-sided ones greater than 2 centimeter are going to be based on size an indication to operate. And so for our patient, of all those criteria, the actual size of his vegetation, which was 2.5 centimeters by 1.4 centimeters, so very large, was the indication to operate on him. So resolution of this case, the patient was put on IV antibiotics. They optimized him before surgery, ended up having triple vessel disease. So they did a cabbage while also putting in a bioprosthetic aortic valve, or mitral valve. He had some AFib. So they did pretty widespread cardiac surgery. And then he was he's in the hospital for a bit, and then they just charged him out eventually on IV antibiotics. So, yeah, I thought if you guys have any thoughts on any of those, I thought it was a super interesting case and really interesting and awesome to hear you guys talk through it. And then I think, like I said, that one of the reasons why I picked this one is just because I think that endocarditis is so interesting just because of how systemic it is. And so it makes it such a good disease to study, like for anyone in medicine, because pretty much every single organ system can be affected by it. So yeah. Kevin, did you have any thoughts or?
Yeah, no, that was a super interesting case. I think, just like how broad back pain, how broad anemia is, like you threw stuff at us that was like really interesting to kind of put together. So that was interesting to work through. And then the one thing I wanted to kind of mention about, the final bug that was discovered, from what, if I remember correctly, I think if I had to pick this or Bovis galolyticus for this man, I'd pick Enterococcus. First of all, if I remember correctly, Bacalis, I think that one's like less known to be vancomycin resistant, which is always a good thing. And then second, so if we're like making the classic like correlation to it, right? So then I'm not as concerned that this man has colorectal cancer, right? Because if it's in Enterococcus, you think of like after procedure versus, if he came back with galolyticus, then I'd be more concerned to look for colon cancer, right? So I think I'm definitely feeling better that it's Enterococcus. Obviously still an awful outcome like that cabbage and that's all those surgeries he had or obviously could have been easy, but I think it's good that at least colon cancer isn't also in the mix.
Yeah, I also like how you mentioned the treatment in terms of resistance. So yeah, vancomycin resistance in Enterococcus is something that we really always are worried about as well. I'll say for this patient, he was ampicillin sensitive. So they did alters it. They took off the vanc and treated him with ampicillin and I think ceftriaxone, but I'll have to double check on that. But also, yeah, another really good point there.
Aaron, any final reflections before I bring things home for us?
Yeah, I'm mad it wasn't strep bovis. I really wanted to tie that all in together. Come on.
But for the good of the patient,
I
got this. I was just going to say this was a blast. I liked working through this. It's a great thought exercise, and to do it with Berto, it's an honor. Like I said, you were the brains behind the operation.
that was a lot of fun. Thank you all. Thanks, Aaron.
Guys, just from the listening seat that I got to sit in, I'm excited for your careers. You're at the tail end of your M3 year and a budding internist, maybe cardiologist and budding neurosurgeon. You guys, your clinical reasoning is just on point. I think you guys should feel proud. And patients that you have the opportunity to take care of they'll be lucky. This guy would have been in good hands to have you guys on his team. So it's really exciting to hear that. And Nick, you just did a fantastic job with this case. One, putting it together. Two, walking us through it and leading us in discussion. You have a career yourself as a clinician educator, and I'm excited that you're excited about this stuff and so willing to work with what we're doing here at Alert and Oriented.
Appreciate that. And also just wanted to kind of add on that, I was super excited to hear Aaron and Berto kind of go over this one. I picked you guys because I know you guys are super well spoken, and it was really fun to hear you guys kind of talk through this. And like, I'm so impressed by how everything was eventually put together, because this is something that, even the diagnostic team in the hospital, like, they struggled with it until there was that acute event on day 4. And like, there was a normal echocardiogram before they did an MRI as an outpatient, did not show septic arthritis. So Kevin and I were kind of talking about some of those things before the cases. Like, a lot of things were kind of leading away from it until you guys were overwhelmed by the evidence and put it together. So, and then, lastly, Kevin, thank you so much for kind of really organizing this. You're pretty much the brains behind all this. And so looking forward to future episodes and kind of hearing what other people have to say.
Yeah, no, thank you. And I'm just happy to make some smart friends along the way. So thank you guys for coming on. And on that note, we'll wrap things up and we'll see you next time.
Thanks again for listening. Person, time, and place. We'll see you next time.